Θα παρουσιάσουμε ένα περιστατικό από το Ιπποκράτιο. Ζητώ συγγνώμη εκ μέρους του καθηγητή κ. Τσιούφη, λόγω υποχρέωσης εκτός Ελλάδος δεν μπόρεσε να είναι παρόν.
Can I ask you to talk in English?
Yes, yes, of course,
because
no
you have
problem.
a lot of English-speaking guests, and it will be better to talk in English. Thank you.
So I'm going to present a case of a valve-in-valve patient who was hospitalized to our hospital actually a month ago. She is a 81-year-old female lady with worsening dyspnea and orthopnea starting 3 weeks ago, and she had 3 hospitalizations since the last month. NIHA score 3 to 4. She was hemodynamically unstable and she was in constant need of inotropes at quite high doses in order to maintain blood pressure. Her background included surgical aortic valve replacement in 2011, an EPIC Supra 19mm valve. She had a permanent pacemaker implanted. She was also diabetic and hypertensive. She was on maximal medical treatment and high doses of diuretics as well. This is her ECG, sinus rhythm. We see the block also from the pacemaker. And now we can see the first images when she came to our hospital, except for the aortic valve that had the major problem. We also can see that there was quite severe mitral regurgitation as well, dilatation of both atria. And here we can see that there is a dysfunction of the aortic valve that was implanted 13 years ago, actually. Her ejection fraction was approximately 45%, and as we can see here, the mean gradient was approximately 23 millimeters mercury, and the aortic valve, the max, was 3.5 meters per second. So we are talking about the low flow, low gradient, severe aortic stenosis, and as we can see here also, she had at least moderate tricuspid regurgitation as well. Concerning our patient, we can see here that we're talking about a lady who had the first valve implanted 13 years ago, and now she is 80 years old, as we can see here at the diagram. There is a degeneration of the valve, there is a failure of the valve. We can see that the durability of the valves implanted, either transcatheter valves or surgically implanted biprosthetic valves, have a durability approximately of 10 years, and there is a dysfunction of the valves. We can see that by these diagrams that the gradient is a bit more in case of a TAVI and a bit less in case of a surgical implanted valve. And as far as the outcomes of valve-in-valve in case we need, because of the patients are nowadays having their first implantation at a lower age, so they might need a second valve as well. We can see that approximately the percentages are the same in case of a TAVI or a TAVI in a surgical implanted valve. The numbers speak by themselves, I think. As the population is getting older and older, more and more patients are in need of a valve implantation of the aortic valve. And comparing the surgical and the transcatheter implanted valve, we can see that the surgical is better in case of coronary obstruction if we need to do is worse, I'm sorry, worse, not better, if we need to do a TAVI in TAVR instead of a TAVI in TAVI.
So, sorry for interrupting you. So the aim of this TAVI round is to have an interactive discussion. So before we move to how you deal with this case, can you prescribe for us what is the properties of this EPIC valve, this degenerated bioprosthesis? Is it a standard valve?
Yes, the diagram I also think is a standard with externally mounted leaflets valve, yes. I'm going to show also the characteristics of the valve later on. The ages are over 9 because the mean age of the valve, prosthetic valve, life expectancy is approximately 10 years. The lady is over 10 years, as we already saw. And just in order to say before I answer your question, of course, is that in the case of the lady, we concluded that it was a structural the reason for the dysfunction of the bioprosthetic valve. And I'm going to show the characteristics as well. We had a heart team, as we already said, because it's a lady that not only had her aortic valve dysfunction, there was also severe mitral regurgitation and a moderate to severe tricuspid regurgitation as well. And the lady was in need of inotropes all the time she was hospitalized. So, depending on the guidelines and based on them, we know that the transfemoral approach of a valve-in-valve procedure has a 2A recommendation. And even if it's not the aortic valve, we can see also that the mitral tricuspid is 2B recommendation. This is the Euroscore 2 of the lady. It's quite high, as we can see, and the STS score as well. And the lady had a coronary angiography actually 2 months ago. She was, the coronaries were fine, not a problem, fortunately, by there. And the main problem of the aortic valve, except for the stenosis, was as well the aortic regurgitation, as we can see here by the aortography of the patient. So, as far as the valve selection, as you already mentioned, and thank you very much, we all use the app that we know that nowadays is used, and we see that we have quite a few options, but some of them are used with caution. So, depending on the data we had and the fact that the lady could not have a CT as it should be performed because she was inotropy dependent and she couldn't be easily moved to another facility or to do the CT, we can see, I'm going to come back just to say that the valve used, the EPIC Supra, is a stent post the leaflets valve. It's not bovine, the pericardium used. It was 19 millimeters, and it's a valve that can be fractured as well. It's good to know, of course, that before we decide what to do. So, depending on the algorithm used, we decided to have the second valve, that was implanted, was a 23 millimeter Evolut R. We had in mind that we might need it to fracture the valve depending on the hemodynamic status of the lady.
Okay, thank you. So we have a lady of 81-year-old with a failed bioprosthesis,
yes.
Extended internally mounted valve,
yes.
With stenosis and bifurcation.
Yes.
Any thoughts about the coronary protection of the coronaries in this case?
Yes,
Any
of
thoughts
course.
about? Of course, this lady has already a pacemaker.
No problem concerning heavy.
What about the coronary protection? Any thoughts about that?
Yes, of course. It was always in mind that we had in mind that we might need to use the basilica and the chimney technique are the most used ones, of course. But we had also the chance to do. I just don't have the image to do not a full study of TOE and also to measure from the CT that we had was not for the preparation of the TAVI. We had a CT just to know if there was any other problems because there was also some markers of inflammation increased, and we thought that maybe there was also the endocarditis, the reason that had a role for her dysfunction of the valve, but nothing was. We could not.
The VTC of this case, it was good enough in order to.
Yes. And also the coronary ostal was above 12 millimeters. That's it. And also the sinotubular junction, there was quite enough gap, so we were okay, and we also did quite a few times. The reason why we did not also decide to do so was because she was quite frail, the lady. That was also the reason why we used the transradial approach for the second approach, while most of the times we use both femoral arteries.
In valve cases or in all cases you use the radial axis? What is your strategy? What is your policy?
Yes, most of the times. If the radial axis and the patient has the body structure that allows us to do, because most of the times we use left radial axis, we use the radial. But if there is a problem,
Yes.
Any thoughts about surgery in this case? Is it a surgical candidate or do we go straight forward to TAVI? No thoughts about surgery?
Given the age of the patient and the fact that the coronaries are normal, so we're not really concerned with reaccessing in the future for coronary artery disease the coronary circulation, just avoiding obstructing the coronary circulation, I would proceed with
yes.
TAVR.
Valve in valve. See what Hippokratio has done in this case. Would you protect the coronaries with a wire, at least a wire, or no need for that?
I don't see any need for that. There is adequate height.
Okay.
There is a wide sinotubular ejection. That's what I'm told.
To be honest, at the heart team, the cardiac surgeon, because in our hospital there is a cardiac surgery unit and clinic. It was debatable, but the risk was too high, and also the anesthesiologist said that she won't make it through surgery.
Any comments from the audience? No. Okay. Yes, go ahead.
Were you preparing for a frac just in case? I know it's an older person, probably not that big, but and then were your measurements in CT big enough, considering that you might have to frac, even with the self-expansion?
So in this case, Dr. Valiano, would you think that a pre-dilatation is better or a post-dilatation is safer?
I think I like to post-dilate, and in this case, especially with a bioprosthetic valve that's already leaking a lot, I'd worry about pre-dilating and then the patient crashing.
Thank you for your comment.
Forcing valves tear. Pericardial valves are tough, they don't tear. You dilate the forcing valves don't tear. They go from moderate to severe AI linear and real flex.
We did the exact same thing. We post-dilated the valve, just like.
So you did a pre-dilatation,
post-dilatation. Yes,
okay.
yes.
All right, yes. This is the
valve.
Evolut Pro 23 millimeter
Yes,
valve?
yes.
Okay. And the post-dilatation with an 18 millimeter
yes,
balloon.
and this is the autography post-dilatation of the valve, which was quite convenient for us, depending on the patient and her background. The femoral artery was okay. We used a Manta 14 French in order to seal the artery. And
is this the Manta the main device you use for closure? Or what is your strategy
yes.
in Hippokratio Hospital?
In most of the cases, yes, but we also may use Proglide. But in most of the cases, nowadays at least, yes, it's the Manta, 18 or 14 millimeters. And after our procedure, the patient was hemodynamically stable.
So I suppose there was a case with a conscious sedation, no transesophageal echo.
No.
You don't use transesophageal echo at all?
We might use it. No, it's not everyday practice to use it, even in valve-in-valve patients who are riskier patients most of the times. But if needed, yes. We don't have much experience on ICE, for instance, no.
Yeah. Okay, thank you.
So, just...
yes, there is a comment from the audience.
Of course, of course.
Go ahead.
With Professor Chouvis, I'm Assistant Professor Dimitriadis. We have done this case. Actually, this is one of the cases of urgent TAVI. I think this is something that's growing also in the publication. And I think if we haven't done this operation, the patient will definitely gonna end. And so we did our minimalistic approach. We tried to do the radial approach. We just do an orthography. And based on the results, we can say we were a little bit lucky, because sometimes you would want to be lucky in such kinds of situations. We haven't cracked the valve. We were not so sure about doing this. So we have done, as you see, the dilatation and afterwards the post-dilatation, and the results were just fine. And what we have seen, and also Irene gonna show us, is after the position of the valve, the patient really get well with conscious sedation. That's what we do in Hippokratio in all the cases. And then also the MR and the TR really ameliorated. This is something that we see, but you're not quite sure. And actually, there was a heart team that was done 5 continuous days. The patient was in the ward, then it went down to the intensive care unit with inotropes. Nobody will try to touch her. And then we said, it was Wednesday morning, okay, let's do let's proceed because there was no other choice. And I think all in the audience, you're very experienced operators. You have cases like that, and this is one of the cases that we really are happy that we have proceeded.
So it's our experience too that when we have severe regurgitation, the improvement of the patients is impressive, and these patients are improving more impressively.
The amelioration of the clinical status of the patient was really something that we not really expected afterwards, just after the case.
Is there any specific reason you choose the self-expanding valve instead of a balloon expandable in this particular case? For example, a Sapien 20mm valve could be used in this case with good engagement of the coronary in the future. Although it's T1, maybe you will never need that. What was the reason you decided?
I definitely agree with you. And a balloon expandable as a first case will seem to be a little bit a reasonable choice. However, we have more experience with this platform as a team, so we chose the platform. I think it's very.
Maybe with the results of the SMART trial recently, this valve is ideal because you have a better hemodynamic profile, and the gradients will be lower. The aortic valve area will be
exactly. But of course, there were not. I think in TAVI. In TAVI, it was in the SMART trial was in was for small annulus, you mean, but not in an annulus caused by degenerative valve already put into place. So, of course, if we can do it.
Okay. And also the coronaries that were was another reason why the balloon expandable that has shorter frame and shorter valve, it was a second choice. Just in order to close the case, if there is no other comment, there is only a small paravalvular leak of the second valve implanted. Also, the gradient was 16 millimeters and 2.5 the aortic valve speed also. And just a few words in order to say that, as we know, there are a few different types for biprosthetic aortic valve dysfunction. In our case, it was structural valve dysfunction. And as we know, the mortality, even if we are doing a TAVI and not a bioprosthetic valve that is surgically implanted, we know that there is a better mortality rate than in cases that we decide to exclude, to explant the TAVI. And also, as far as the choice of the valve that you already have mentioned, we do know that there is a larger effective orifice area in case of a self-expandable valve, but the balloon expandables have a lower rate of dysfunction of the valve, type 1 dysfunction. We already mentioned the VTA and the risk plane that it was okay. The basilica, as you already mentioned, that we did not need to do that, but we were prepared if something went wrong that we might need to protect the coronaries as well. And we remember the general rules in case of TAVI that balloon expandable, same size, but balloon in itself, we downgrade the size a little bit. Just as far as bibliography is concerned, the registry of explantor TAVR showed that the TAVI explant was done quicker than TAVI, but better results long term. And as far as our choices are concerned, we need to know, of course, the patient and his anatomy quite well. Also, if we have the right measurements, as far as the CT is concerned, it's the optimal for our preparation for the procedure. And also, be ready for everything that goes wrong, even if it's the valve itself or maybe also the arteries of the feet. Just a few words. Recently, Dr. Dimitriadis, Professor Tufts also, and myself, we had a meta-analysis including 17,000 patients that we compared TAVI in TAVI or REDO in SAVR patients. We saw that the reintervention was the only fact that favors REDO, SAVR, and valve in case of transcatheter valves was better as far as new pacemaker implantation was needed, the stroke at 30 days and the MI at 30 days, and also, of course, the hospitalization that it was fewer days. The only points that were better in case of surgical valve was the mid gradient after the valve, as we saw in the beginning, also the paravalvular leak. And in conclusion, I would like to point out the fact that with Professor Tufts and his will, we started a registry in our hospital that includes all Greek hospitals, of course, for everyone who would like to participate in patients with symptomatic severe dysfunction of a biprosthetic valve implanted. And the primary endpoints are all-cause and cardiovascular mortality and ischemic composites. So, given the fact that the number of patients who need valve-in-valve procedures will increase due to the longer life expectancy nowadays, we need to say that we need to know the anatomical factors as well as meticulously have the data from the CT scan and also know the valve that we are going to implant in order to better position a size and to avoid all the major problems that may come in the near future. Thank you very much.
Thank you very much. Let me take the opportunity, since there are so many prominent surgeons and interventional operators in the audience, and ask a very simple clinical cardiologist question, but it may be complex also. What would be the valve of choice for a younger patient, 60-year-old, who will need, let's say, for bicuspid aortic valve replacement at the age of 60? Would it be a surgical valve? Would it be an interventional procedure? There is a chance that such a young patient may need 2 redo procedures in his lifetime. How do you approach this? Or already lived by the success, the immediate success of whichever procedure. But how can we see it in the future? What is the best investment for the patient? Any thoughts? I would invite any thoughts.
Well, we follow the guidelines. If you're healthy, you're 60, you're going to get surgery. The saddest thing about this case to me is she had a 19 valve. It's sad when a surgeon puts in a 19 valve or a 21 valve. In my operating room, the rule is no woman leaves with less than a 23, no man leaves with less than a 25. So if your surgeon's putting in 19 and 21s, you better just do a TAVI or get a new surgeon. But I think for somebody 60, you know, they need if they want a biologic valve, mechanical valve is fine too. But if they want a biologic valve, pericardial, don't use porcine in the aorta. They always have more obstructive flow, and they also fail by AI, which is a quick failure. And make sure your surgeon puts in a reasonable valve. You come out with a 25 or 27 valve, not only is it going to last longer, but when it comes back to the cardiologist, you are now a better setup for a valve and valve. But 19, you should never, that's sad.
Well, I mean, for the bicuspid scenario you presented, clearly the surgery would be the first choice. The more tricky part is, though, becomes really interesting, what's happening with that same exact patient who's going to go for surgery and the aortic size is 4.1 or 4.2, very common sizes. And, you know, how do we deal with that? It's okay to go for surgery and not replace a ascending aorta. You're replacing the ascending aorta. That is always a tricky one. And I don't think we know enough about that. I would welcome any research advices also over the time about this thing, because there may be some biomarkers we're going to have to find to indicate who are the people who are prone to develop a future dilation of the aortic arch versus of the ascending aorta versus not. I know Dr. Riordan, and I see Professor Choufis also joined. Perhaps he will weigh in as well.
Well, they are developing biomarkers, but we're not going to do genetic biomarkers on everybody. It's just not going to happen. And 4.5 is the guidelines. But again, it depends on if you're a 6'8" man or a 4'10" woman, what 4.1 really means. And at 4.1, there's not a lot of chance it's going to do it. And on the other side of that coin, I'm actually running a type A and an ascending aorta stent graft trial. 5 years from now, we may have a stent graft for this too. I mean, there are things coming down the pike. But at 4.1, unless it's a really tiny person, I'd have a hard time replacing that. Or remember, all phenotypes are different. Type 0 with AI, those will progress. Type 1, they stay stable.
Professor Choufis maybe has a comment, and thank you for connecting.
Yeah. No, just George, I would like to set my being able to connect it earlier due to another commitment in a meeting in Krakow in Poland. So I did attend the session, so just to thank you all, and please go ahead with your comments.
I think we're ready to conclude this case. Thank you for your presentation. It was very nice and elegant presentation of a valve-in-valve case with all the aspects of this technique. Thank you, Professor Choufis. We have to move to Onassis Cardiac Surgery Center and Dr. Iakovou.